not enough. Joe?
Thanks a lot, Jim. Thanks again for your kind invitation. It's nice to see friends in New York. Anyway, this is a topic near and dear to my heart. There's a lot of different ways you can go with this title, I said, but I'm going to take an area that I think may shed some light on what we are doing with patients with complicated type B dissections. So what we know so far is that treatment, or TEVAR, for type B aortic dissection definitely reduces mortality compared to open repair. Rupture and malperfusion are effectively managed with TEVAR, and I use the word managed because it's a real long-term effort. I don't think anybody's truly treated unless you can completely ablate the false lumen in one shot with TEVAR, which is rare. And then secondary interventions are common to induce false lumen thrombosis, as we're finding. TEVAR does not prevent aortic growth, especially in patients with in the acute phase. The abdominal aorta remains vulnerable and the most difficult areas to treat, particularly in the visceral segment. And really nothing beats sound judgment and good technique. We looked at a series of papers looking at measurements after TEVAR and found that both the thoracic and the abdominal aorta show significant growth after TEVAR and very comparable to patients who are medically managed and medically stable who are untreated. So when we take a thoracic growth component and you look at just the patients with thoracic growth and you eliminate the paper that does not have measurements for thoracic growth, you'll see that you got a 6.6 to 84% rate of growth in those patients. That was over 1,000 patients that we pooled. So it's an overall 33.8% growth rate for patients who are treated with TEVAR in the thoracic aorta, according to these papers. In addition, we looked at abdominal growth. And in the abdominal aorta, you'll find that there is also a significant rate of growth. And you eliminate all the papers that looked at just the thoracic aorta, and we pulled all the abdominal aortic growth, and you saw a range of 10 to 54% for almost 400 patients at 34.5%. So clearly, for those who are measuring and those who are looking and those who are publishing, you're seeing a significant amount of growth, despite the fact that TEVAR was used. So what do we do about it? Well, early growth can be identified with good surveillance, and open aortic repair can be employed once aneurysm is large enough or to justify repair. In addition, endovascular reintervention can be employed before that time with less morbidity if you capture patients on a growth rise. So the realization is that entry tear coverage really no longer seems good enough or enough for long-term management of type B aortic dissection, and a good chance that 33% of the time or 35% of the time you're going to be re-intervening for late-term growth. So we introduced a composite device design in about 2006 with Stable 1 trial, and we completed Stable 2 trial a couple of years ago. And it's introduced the Petticoat concept, which was inspired by Chris Nienaber and Peter Moss up in Australia. And the basic design is proximal entry tear coverage followed by open bare stent, support of the true lumen throughout the remainder of the aorta, or to the extent that you feel that disease warrants it. In Stable 1, it was more of a feasibility study. We looked at all different types of inclusion criteria, which included rupture, malperfusion, and also persistent pain, patients that are poorly medically managed, those with persistent hypertension and pleural effusions. In addition, Stable 2, once we rolled that out, we just distilled the most grave situations. Only rupture and malperfusions were included in this study. And that was also a prospective multi-center study in US and Japan. So we'll talk about Stable 1 because I really feel that it reflects the real world view. I think it captures the indications that most of us are using today for treating our patients. We enrolled 86 patients and a primary endpoint was 30-day mortality. Again, composite device design. The distal bare stent now is a nitinol-based platform. This was a stainless steel Z-stent platform. In Stable 2, we have a nitinol stent. So what we've learned thus far is that the composite device design is effective in restoring visceral and lower extremity flow for patients with malperfusion. Acute dissections remodel differently than do chronics. And you're talking about a stark difference between patients treated before 15 days compared to those treated after 15 days. We also saw paraplegia rates were favorable compared to TEVAR alone. And it owed to, we had a short proximal endograft. We weren't aggressive with covering the thoracic aorta terribly, and we used that dissection stent to really do the yeoman's work for remodeling that aorta. And we found that the paraplegia rates were appropriately lower. So late complications of growth are easily facilitated by the dissection stent over the visceral aorta, and I'll show you an example of that. There are no ill effects of the bare stent to date, no explants, no infections, no direct complications. And here's a cartoon of a patient with some static obstruction, and you can see thrombus in the false lumen. You can see how that intima kind of involutes and pulls away and rips off that intimal orifice of the renal or visceral vessel. And then with the dissection stent in place, it reapproximate that intima back to close, or at least reapproximate it close to where that entry tear initially occurred. So here is a patient that had basically significant true lumen compression, false lumen expansion, and once the dissection stent was placed, you could see that reapproximation really does hold true. In addition, this is a coronal view, and you could actually see the torn intima right here, wanting to mate back with its buddy in the left renal artery. And so if you look at TEVAR alone, you'll see there is a significant length or distance between the septum and the right renal artery. However, with the bare stent, you could see that reapproximation really does give you value if you need to go back in and reintervene. You don't have to hang that stent off of this intima. Rather, you've got your own fenestrated stent graft, if you will, of naturally occurring intima that you could use to support any further secondary intervention. So here again, same patient getting in through the interstices of the stent, getting into the renal artery, and placing our stent. We had to place another stent there because the entry tear was a little further than we thought, and that shut down all of recurrent false lumen flow, and the patient subsequently had complete false lumen thrombosis. Very simple procedure done in the IR suite. Huge, huge effect of dictating that patient's future remodeling. So we won't go through all of this for time constraints, but you could see that we pooled the acute and non-acute patients. And basically, when we looked at everything, there were a lot of different device design usage. So you had a lot of proximal entry tear coverage with multiple proximal stents and multiple distal bare metal stents. Depending on the patient's anatomy and presentation, our investigators were allowed to curtail their device composite. And our mortality was 5.5% for acute dissections, 3.2% for non-acute, and 4.7%, which is really low when you look at that group of patients. You could see the remodeling for both thoracic and abdominal aorta was excellent. So the question was, what is the difference between Petticoat and just TEVAR alone? We looked at stable 2 and stable 1 data and compared that with the SVS data set. Our mortality was lower, our paraplegia rates were lower, and we had basically a real good body of data with positive remodeling, also in the abdominal aorta. And we further strengthened that with an analysis, case matched control analysis of stable patients and TEVAR alone patients, and we did a volume analysis. And we found that TEVAR alone was better in the thoracic aorta with maximum coverage. In stable 1, we covered a little bit. With TEVAR alone group had maximum coverage down to the celiac artery, and they remodel more favorably. Also, paraplegia rates were a little higher. Abdominal aorta grew equally in both groups. And the Petticoat had maximally expanded true lumens and minimal false lumen area compared to TEVAR alone. And the Petticoat had better remodeling of the visceral aorta for the advantages that I had mentioned earlier. And it lends to whether or not branched or fenestrated devices would be better suited in an intima or in a true lumen that's maximally expanded for subsequent therapy if it's needed. So I'll finish with a case presentation. A 51-year-old male, tearing back pain, hypotension, renal failure, liver failure. This guy was circling the drain. He already had an aneurysm of his thoracic aorta, and this was the case that we looked at earlier. He had complete obstruction of his visceral vessels in the celiac and SMA. We basically performed a proximal entry tear coverage and placed the distal bare metal stent. And the guy did great. He was back to work in 3 months. He looked fantastic, except his CAT scan shows aneurysm formation at 3 months. So he's had this visceral segment. It was like the worst area you could possibly have it. But our bare metal stent crosses that area, and here you see a nice maximized true lumen. So we got through the interstices of the stent, basically shot a picture, got into our left renal artery. You could see, I use this just to show you that it really kind of slides through quite easily. And that's our finished results. I beat the shit out of that renal artery with that Rosen wire. But anyway, so he also had multiple re-entry tears distally, and we took care of that with another stent or two, and then closed the left iliac artery fenestration with an iCast stent. And that basically sealed the deal. There was a small amount of flow, remainder from an IMA re-entry tear. So he came back 5 years. This was about 5 months ago. And he just showed up out of nowhere. He was non-compliant. He never came to his office visits, but he showed up one day with a CAT scan, and this is what it looked like. So a complete ablation and thrombosis of his false lumen with positive remodeling. So this guy did actually really well. He was really on death's door. So the device itself really helps people out. I think it minimizes their morbidity. I really do believe the data of improved mortality compared to everything else is real. I tend to use this as often as I can. So in conclusion, Petticoat technique using a distal bare stent for type B dissection is an effective management tool. Stable 1 demonstrates promising 5-year data, and this technique also shows more favorable remodeling of the abdominal aorta with more options for secondary intervention when needed. Long-term failure in the abdominal aorta will be the next frontier in the management of type B dissection. Thank you very much for your time.